Cradled between Chicago and Lake Michigan, Northwest Indiana is the second most populous area in the state outside of Indianapolis. Rising to prominence in the early to mid-1900s, Northwest Indiana was a hub of economic development due to the rise of the steel production and its proximity to the city of Chicago. Of Northwest Indiana cities, Gary, Whiting, Hammond, and East Chicago were especially prosperous in industry and steel production. However, this also uniquely tied their fate to the success of industry. When industry collapsed in the 70s, these cities suffered harsh economic downturn and as a result were plunged into financial insecurity. And this is where the homeless crisis began. Homelessness as a whole is a problem that has only been compounding in the United States, accounting for nearly 650,000 homeless individuals in 2023. The problem has grown into more than just a crisis. In the region, Lake County in particular, local data has counted 701 homeless, a nearly 50% increase from 2022. As a county, I feel that we need to ask ourselves, why is this occurring? Indiana as a whole struggles with homelessness due to a variety of factors. Indiana has generally high eviction rates that particularly impact Black and Hispanic Americans, which also happen to make up a majority of the population in Hammond, Gary, Whiting, and East Chicago. To go along with that, homelessness is often criminalized in Indiana, and as such fines and jail time can create a vicious cycle, making it nearly impossible to get back on your feet. Drastically increasing rent and housing prices over the past few years have further worsened the situation, and African Americans and Hispanics have often faced difficulty in getting housing due to things like housing segregation and redlining. In Northwest Indiana, the homelessness problem has been kicked down the curb for years and is rarely ever addressed by local cities and governments. While going through training to become an EMT, we were taught that almost all tuberculosis cases we will encounter in the field will be among the homeless. We were also taught that the homeless often presented with certain respiratory illnesses in higher rates, such as COPD and bronchitis. In the field, I found this training to be unfortunately accurate. Almost all people that lacked a permanent form of housing presented with some form of respiratory problem. Even if it wasn't a certain illness, O2 saturations always presented a little bit lower than expected, and most had a chronic cough of some variety. But why were the homeless in particular so disproportionately blighted with respiratory illness? Research shows that, unfortunately, my observations are broadly true. The homeless do suffer much higher rates, proportionately, of respiratory illness. Bronchitis, tuberculosis, COPD, and other infectious diseases and chronic illnesses are significant among the homeless populations of Northwest Indiana. Homeless shelters, especially in the winter, are hotbeds for infectious diseases, and when looking closely, it's easy to see why. People who lack a permanent form of shelter often suffer from several key risk factors. Some of these can include substance abuse, exposure to the elements, malnutrition, inability to access medical care, and partially due to the fact that the air pollution in Northwest Indiana is prevalent and worse than in the rest of the state. Even homeless shelters oftentimes have poor ventilation and group these people together, further spreading disease. It's easy to see why they suffer. But why are Northwest Indiana individuals in this situation in the first place? If we could figure that out, we could easily tackle this and prevent the higher rates of respiratory illness. In order to figure out more behind why people are homeless in the United States in the first place, I decided that it would be best to consult an expert. And that's what led me to Brown University professor Dr. Irene Glasser, a leading anthropologist in the study of homelessness. To start, I had Dr. Glasser introduce herself. We then had an open discussion about homelessness in the United States, digging into structural factors that help contribute to homelessness, the why behind homelessness, various models that have been successful in treating homelessness, and certain things that could go a long way to prevent respiratory disease among the homeless. I've included some segments that I felt were especially relevant for my documentary.
Sure, I'm an anthropologist. I've been an anthropologist for a long time. I did my dissertation about, I don't know, 40 years ago, having to do with soup kitchen. It was an ethnography of a soup kitchen, and it was one of the first soup kitchens in Connecticut. And then I think it's still the only full-length ethnography. So I've been doing research on homelessness pretty much ever since, really since the early 1980s. And when all of a sudden we have these people who are homeless, and my basic analysis is because we cut off their money supply. It's a philosophy, change of philosophy. So in the US, we basically it was each man for themselves up until the Great Depression. And this is when so many people, like board of the workforce, were unemployed, that FDR, Franklin Delano Roosevelt, really had to come up with some program. So that was the introduction of Social Security. Um, Acknowledging that at least elderly and disabled people needed help surviving. And then really shouldn't give people cash because maybe they'll spend it on drugs or alcohol. We should just give people things like shelter and food, like literal things, tangible things, and take away their right to make choices. And it really had a bad effect because once a person gets into homelessness, I feel it's hard for them to get out. So they might sleep in a shelter or maybe in an encampment or maybe transitional housing. But I've done evaluations on programs that do help people get out and get permanent housing. And those programs work, but they're not at the scale that they need to be. So they might sleep in a shelter or maybe in an encampment or maybe transitional housing. But I've done evaluations on programs that do help people get out and get permanent housing. And those programs work, but they're not at the scale that they need to be. So we still have people coming into shelters and it's really no way to live. I mean, living on a cot in a dorm and having a little locker and having a lot of them you have to leave during the daytime. It's really hard for people to get any kind of help, you know, in that position. So that's where the idea of housing first came from. The other concomitant kind of thing that happened in the set actually was starting to happen probably in the 60s or 70s is the lack of public housing. We stopped building public housing. Public housing became very looked down on, the projects. And so we stopped building public housing, which was a real problem because that housing then deteriorated and we didn't replace it. So we have I'm very much into the structural issues, yes. So these people who were their clients were able to access housing and it was phenomenal. It was a really successful program. So I think having the mental health substance abuse organizations themselves expand into the area of housing, which a lot of them don't do, they don't want to do that.
Yeah.
But I think that's really helpful to their clients.
Yeah.
Are big, usually community health centers that are for people with low income or underinsured. And now with Affordable Care Act, they help people get onto, let's say, the state Medicaid program so that they can afford health care. So getting people into healthcare is great, like getting them a primary healthcare provider.
Yeah.
So that they take care of their chronic problems. These
Yeah.
are, I mean, we've actually practically cured TB. But yeah, I mean, it's healthcare that hasn't been taken. It's people's health issues that have not been attended to.
Yeah.
So you go
Because
from, a little problem to something like way out of control.
Mhm.
Like when I interview people who are homeless, and they tell me their health problems, and let's say they have high blood pressure, I say, well, are you taking your blood pressure meds? And they say, oh, I haven't done that for a year. I mean, they just haven't. either gotten
Yeah.
their prescription or their prescription refilled. That's like, well, they might have a stroke
Yeah.
with COPD. I mean, this is a good example. If
Yeah.
you are closely monitored and you go to the clinic and you take, all those pulmonary tests that they give, and so somebody can adjust your medication, and if you can get your medication, I mean, this makes you like not have those crises. But or any other chronic illness, like high blood pressure, heart, diabetes. Um, yeah, I think the constant, healthcare monitoring is really, really helpful. Is successful, vans on the streets. And for example, in Providence, there's a program called Shower to Empower, and it's vans that have showers in the morning. So they'll park at a place where they know a lot of people are homeless, and they have enough showers for 29 showers, hot showers. But also on those vans, there's usually some caseworkers and nurses. So it's kind of outreach for health as well as getting people started on the road to filling out forms for housing. So outreach is like really important, I think.
Mhm.
So we have kind of a competitive system, and I think that's a problem. Like if
Yeah.
you compare us with other countries where the governmental agencies have more responsibility to help, I think that I think we have a lot of, like I said, a kind of a dysfunctional system.
Yeah.
So I think it's good to keep your ears open for, you know, how do these organizations work together, or do they not work together? For example, I'll end on this note. I evaluated a program in Rhode Island, and Rhode Island is a very Catholic state, and they had a lot of convents,
Mhm.
nuns who lived in convents. And they took one convent that was on a major road. There was a bus right in front of it, and there was so what they did was they rehabbed the convent into 11 apartments, and they're small apartments. They're, what you might call studio, but you walk in and there's a barrier on the other side of the barrier. There's your own bed, a desk, a kitchen area, a bathroom, and the building is locked. People
Mhm.
feel safe. And my evaluation is people, once they get there, they stay there forever, because and these are all people who are literally homeless. So that was a great project. And I've seen other places in the world. So it helps people get into apartments, real apartments, not just like sheds. Um, and it's remarkable, even a person who is addicted, if they move into an apartment that's their own apartment, like 85% stay there. Now, they have to be a good tenant. I mean, they can't turn it into like a crack house or anything, but if they're a decent tenant, which means paying their rent, which is usually 30% of their income, that's the standard in the US. So it really works. Oh, and the other concomitant kind of thing that happened in the set actually was starting to happen. I've seen other places in the world where they rehab something that could be housing, like an old factory, or like I said, convent is a great example, because the convent already probably had communal rooms also,
Mhm.
like a lounge and maybe a big kitchen. But I think it's essential for a person to have, you know, enough private space where they have their own bathroom and their own kitchen area. And the country, I mean, there's many countries that are models in the world. They don't look a lot like the US, like Finland has
Yeah.
practically no homeless people. But the answer there, when you look into it, is yeah, because the government runs the programs, and they absolutely can build more housing because it's the government. They
Yeah.
don't leave it up to the nonprofits, and they don't leave it up to the neighbors. And they can give out money to rent apartments. They have a lot of power. And we really don't have that kind of system. We have all this, all these nonprofits who kind of do their own things and then deal with the neighborhoods. So, but anyway, I think so that's a problem. But
Yeah.
since I was alive and, you know, knew about this kind of thing before we had this big homelessness problem, I say yes, because I remember the time when we did not have shelters all over the place and soup kitchens. I remember that time. So I would say yes, but timely, I don't know. I mean, I think one thing, I'm very in favor of housing, but I'm not so in favor of encampments.
Yeah.
I see encampments as being, not getting people anywhere. They're dangerous and they don't, people often don't get out of them.
Dr. Glasser certainly gave me plenty to chew on, but I think that with talking to her, I have finally identified what I believe can help mitigate respiratory disease among the homeless in the region, as well as identify factors that can one day, hopefully, even bring an end to homelessness in the region altogether. In terms of mitigation, I have identified a plethora of solutions that I believe could help mitigate respiratory illness among the homeless. The first is increased access to in-shelter care from trained professionals. As Dr. Glasser mentioned, when bringing in trained healthcare professionals to shelters, the shelters were wildly successful in curbing illness and keeping tenants healthy. Another possible solution is increasing the visibility and providing transportation to FQHCs in the Gary, Hammond, Whiting, and East Chicago areas. There are quite a few federally qualified healthcare centers in the area. However, the homeless in the region rarely access these resources for a variety of reasons. Some simply don't know that these centers exist and that they can help for supremely discounted rates, and some don't have the transportation necessary to reach these centers. Increasing visibility and providing transportation would allow the homeless of the region to treat respiratory illness early, before it becomes an emergency. Better access to smoking cessation care is another idea that has seen great success in other places around the United States. In Rhode Island, for example, the state was able to provide homeless individuals with quick coaches and nicotine replacement therapies, which greatly lowered both smoking rates and deaths from smoking-related illness among the homeless populations. Ultimately, preventing homelessness is the single best way to curb these respiratory blights. I have identified a few possible solutions to help get the region on the right track to getting people a permanent roof over their heads. Public works is a strong idea for generating jobs in an area that has been ravaged with unemployment. Almost nothing can match the industrial system in terms of jobs generated. However, public works would not only help people get jobs and more money in their pockets, but it would also help to repair the crumbling infrastructure that dots the landscape of the region's cities. Tested and proven in the Great Depression, public works could go a long way in helping to restore the area to its former glory and keep people in warm beds and walled rooms. The Veterans Administration is one of the most successful models to combat homelessness that has ever been introduced in the United States. Of this model, I believe that widespread application of the HUD-VASH system in a local population context could do wonders in reducing the amount of homeless in the United States. HUD-VASH is collaboration between the VA and the U.S. Department of Housing and Urban Development. It is essentially a program that provides veterans with HUD housing vouchers, which assist with rent payments, as well as VA case management and health services. The goal is to ensure that veterans are not only housed, but also receive necessary support to thrive in their local homes and communities. Applying this to ordinary homeless people could not only help get them in warm beds, but with case management and access to health services, these people could finally escape the cycle that they've been so viciously trapped in. Homelessness is a scourge. Because of it, hundreds of people in the region suffer from respiratory illnesses that they likely wouldn't have experienced otherwise. However, we as a community in the region often do so little to help these people in need. Helping the homeless survive is the status quo. but also the bare minimum. If we want homelessness and the respiratory illness that accompanies it to finally be put to rest, we must not only help these people survive, but help them thrive as well. For thriving is the only way that these people can finally break the cycle. I think Daniel Quinn said it best. Don't try to drive the homeless into places we find suitable. Help them survive in places that they find suitable.